This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Stacey Clardy from the Salt Lake City VA and the University of Utah. Today on the podcast, we are joined by Bhooma Aravamuthan from WashU, where she is a pediatric movement disorder specialist and neuroscientist studying dystonia in cerebral palsy. We're talking today about her recent paper on cerebral palsy. The title of that is Uncertainties Regarding Cerebral Palsy Diagnosis: Opportunities to Clarify the Consensus Definition. That is in the December 2024 issue of Neurology Clinical Practice, so that you can look it up, because we will talk a lot today, but probably only scratch the surface. That paper has a lot of great information. So, Bhooma, I'm an adult neurologist. I confess that I don't know exactly what is encompassed by cerebral palsy. I feel silly saying that. The diagnosis has been around for so long, but in the modern era, can you tell us what is the modern definition of cerebral palsy?
The current definition from 2006 notes that CP is a permanent motor disability due to a non-progressive disturbance in the fetal or infant brain. And that is the bare bones summary of what CP is. Just like other quintessential neurodevelopmental conditions like epilepsy and autism, you can have CP due to any number of causes: genetic, trauma, premature birth. And just like epilepsy or autism, CP can look really different person to person, but that's the unifying clinical assessment: a permanent motor disability due to a non-progressive disturbance in the fetal or infant brain.
Okay, I think I understand that definition. So now let me give you an example. So if I see, and usually for me, adult patient who has in the modern era a well-defined genetic condition that caused an injury, do I call them cerebral palsy or do I call them by that genetic mutation? I guess it's more of a philosophical question. Should we be aiming for more precision in our diagnostic labels in this category? Should we move away from the term cerebral palsy, or am I missing the point? Is cerebral palsy allowing us to classify things in a way that's better for the patient? So I guess what I'm saying is, what's the ideal nomenclature?
You're right. That definition has been around for a really long time. That version of the definition is from 2006. But definitions of CP that sound a lot like that have been around for decades. And I get asked this question often, Stacey. And when I am asked this question, particularly as a neurologist, I think back to how we don't necessarily ask ourselves that same question when we make an epilepsy diagnosis. So we would, for example, if a person has epilepsy due to a genetic condition, let's say GRIN2A variants, we would never say, oh, you don't have epilepsy anymore, you have a GRIN2A-opathy. So just like we say epilepsy due to XYZ, autism due to XYZ, we should also say CP due to XYZ. And there are many reasons for that. One is we've previously shown that when we ask the CP community, and that's people directly affected by CP and their families or caregivers, that the CP community overwhelmingly prefer to keep the CP diagnosis together with an etiologic label. So that goes back to the CP due to XYZ, due to genetic condition, due to premature birth, et cetera. And that's for many reasons that they stated. One is for access to a community of people with shared experiences that a rare condition diagnosis would not provide in isolation, because we're really narrowing the population of people that constitute that community. It's for access to services in many parts of the United States in particular. It's for an understanding of the evolution of their symptoms, and it's for a way to explain their symptoms to other people. And beyond the value to the person directly affected, and one might say that that value should take precedence over all else, but even beyond that value, just like saying epilepsy is valuable to trigger screening and treatment recommendations, like when two medications don't work, you should consider epilepsy surgery, saying cerebral palsy also comes with screening and treatment pathways that are difficult or maybe even unnecessary to tailor to each individual etiology. And the CP field and the CP community, therefore, together generally stand firm on this. CP as a diagnosis should be given together with the etiology, and one should not replace the other.
And I'm thinking about it again in my role as an adult neurologist, seeing folks who maybe had the diagnosis of cerebral palsy given when they were very young, and now maybe they're in their 30s or 40s. So perhaps if I'm understanding correctly, my role should be if I just see cerebral palsy, no etiology described, no further details, my role is to then say, okay, CP, do two, if I can figure it out, if the patient's interested in exploring with more of the precision diagnostics we have available now, and to see if, in addition to the cerebral palsy community resources, there might be something in getting that more specific diagnostic granularity that might change what we do for them as an adult. Is that fair?
You got it, Stacey. That's perfect.
Okay, I've got my instructions. So with that in mind, let's go back to your paper. So tell us, what did you do specifically in this paper?
We've already noted in our previous work that even though there's this longstanding definition of CP, the permanent motor disability due to a non-progressive disturbance in the fetal or infant brain, that definition from 2006 is variably applied in clinical practice in a lot of different clinical scenarios. And then we also found that, at least in North America, child neurologists and neurodevelopmentalists play a huge role in diagnosing CP. So in this paper, we tried to figure out why child neurologists and neurodevelopmentalists may variably apply that 2006 definition, and what aspects of the definition may be difficult for them to interpret practically. So to do this, we elicited feedback on the 2006 definition at a seminar at the Child Neurology Society annual meeting a couple of years ago. This is the largest conference in North America for child neurologists and neurodevelopmentalists. And I'm still blown away by this, but half of all conference goers attended the seminar and provided feedback. So this is obviously a hot ticket item in the field. And they overwhelmingly felt the definition should be clarified to address two areas where they had some confusion about how that definition was worded. One is how to define non-progressive disturbance. What do we mean by that? And the other one centered around age. So how early can you diagnose CP, and how late can you sustain a brain disturbance and still have it be called CP? So to address these uncertainties, we did a deep dive into the literature on CP, tried to synthesize it in an evidence-based way to address these uncertainties. And based on this, we proposed operationalizing the 2006 definition to note that CP is a lifelong motor disability with motor symptoms that start by age 2, that can be predicted to cause or observed to cause motor disability without loss of previously acquired motor milestones by age 5. That's a lot, but some key features there are the age cutoffs that we chose and being explicit about that. And that's evidence-based on neurodevelopmental literature and CP motor development literature. And it also allows us to be very concrete about how to practically apply the CP definition in clinic. The other key feature of this is the word predicted. So you can diagnose CP very early as long as you can predict that it's going to cause motor disability without loss of motor milestones by age 5. And there is a large body of literature now that allows us to predict whether someone will have CP at a very early age. And sometimes that's within the first several months of life. And then the last aspect of this that we found valuable to address those uncertainties, that it defines this concept of non-progressive, not by the etiology, which can be difficult for genetic etiologies of CP that have variable genotype-phenotype associations, can also be difficult knowing that CP manifestations change across the lifespan, particularly in adulthood. So now non-progressive is defined in this formulation phenotypically in early childhood, which gives a more concrete way and a more hopefully consistent way to diagnose CP clinically.
This is very helpful. Again, I have my lens of an adult neurologist I'm framing this through, but if I do see an adult patient and they tell me, actually, this movement disorder didn't start until I was 12, and there's a cerebral palsy diagnosis in there, I really need to be digging in to figure that out, as one example, right?
That's absolutely right. Yeah, if their motor symptoms didn't start until age 12, they do not have CP, and they likely have a different condition that needs to be investigated.
Yes, this is really helpful. I love this. So this is, in fact, making cerebral palsy more precise while still keeping it inclusive to the community is sort of what I'm hearing you say was the result of the project.
That's absolutely right. And those words are so well chosen, Stacey, and that was our goal. We want the definition to be inclusive, but we also want to reduce diagnostic variability. We want to give the clinician, the neurologist, the tools to be able to confidently make a CP diagnosis and understand what that means across the lifespan. And to do that, we felt that we really needed these operational criteria.
As we wrap up, final thoughts for us in clinic, how to approach cerebral palsy. You see this, you're an expert.
So I would say first that it's important for us to see people with CP in our practice. And I don't know that that is necessarily common practice across all of neurology. And I think that we've both emphasized that throughout this discussion. CP is a quintessential neurodevelopmental condition. Most people alive today with CP are in fact adults, and they all need neurologic care. So I would say first and foremost, say yes to seeing people with CP in your neurologic practice. Second, when someone comes in with a CP diagnosis, just as you pointed out, Stacey, earlier, do your best to identify an etiology and to discuss that with the person and the family. And if you can identify an etiology or you're not sure, it's okay to say that and it's okay to document that. I think going through the diagnostic odyssey and letting families and people with CP know that you're looking is important. And also, Stacey, as you said earlier, identifying that etiology could also be helpful for developing screening recommendations or treatment recommendations. Third, document that person's baseline function. And that's true for neurology in general, but it's particularly true for people with lifelong motor disabilities. And know that changes in baseline function for a person with CP warrant investigation. So adults with CP have a higher probability of stroke, of myelopathy, of dementia, of new onset epilepsy than adults without CP. So make sure that you're investigating those potential causes of any changes in baseline function. And lastly, there are care pathways and screening guidelines available for cerebral palsy for free through many organizations, namely through the American Academy of Cerebral Palsy and Developmental Medicine. And I would really urge everybody to take a look. There is a lot of data and help out there for caring for this population.
Wow, that's a very important piece that I also hadn't put into my to-do list, which is to screen more rigorously for a lot of these common adult stereotypically conditions that you've just mentioned there. And I didn't know that statistic. It makes sense potentially, but really keeping an eye out for development of epilepsies, other neurologic conditions with perhaps more of a focus in patients who have cerebral palsy listed in their past medical history, as it were, on the adult side. That is a very important tip. I've been talking with Bhooma Aravamuthan from WashU about her paper. Again, the title is Uncertainties Regarding Cerebral Palsy Diagnosis, Opportunities to Clarify the Consensus Definition. It is in Neurology Clinical Practice, officially the December 2024 issue, but you can find it online right now. Thank you, Bhooma.
Thanks so much, Stacey.
If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes, or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.